All right. Hi, everyone. My name is Ankur Gupta. I'm a general dentist in Cleveland, Ohio. I want to make sure that I'm respectful of the timing for everybody, so I'll wait until it's exactly 8 o'clock before I get started, and that'll give every one of you a chance to filter in here. And now it is 8 o'clock. My name's Ankur. I've been a dentist for almost 25 years, and I I know how I know how much I don't want to attend webinars when it's nice outside in a summer evening. And so the fact that you all are logging in, that the majority of you are actually going to pay attention, that means a lot to me. And I want to make sure that this webinar is actually useful. So let's get started. This lecture is brought to you by Catapult Education, which is, in my opinion, one of the best platforms of education, both live and online. And the sponsor of today's event is Cavo. You know Cavo probably because of their handpieces. I will be talking about some Cavo products. I won't be sly about any of that. I talk about a variety of products and strategies in today's lecture. But I just want to make sure you all know that Cavo is today's sponsor. They are taking care of the honorarium for me. And at the end of today's lecture, they will be providing you with some additional information and content. This is my daughter, and when like this kid never had a cavity. I mean, up until age 16, her teeth were pretty much flawless. And um, after she turned 16, I she got her driver's license, and she started going to Starbucks because she could drive. She had that independence and she could drive. And every time she would go to Starbucks, she would get probably some, 500 calorie, 90 grams of sugar, something in her whatever coffee drink she was getting. And her first exam that she did at our office after she had, when she was like 16 and a half, 17 years old, we took these bite wings and just look at these suckers. I mean, this kid who never had a cavity before, who had pretty flawless teeth, all of a sudden I was looking at my own kid, the daughter of a dentist, and how many cavities do you all see here? How many cavities do you see? Let's see if I can open up my chat. That'd be kind of fun. You know what? I can't open up the chat. But so go ahead and just think about how many cavities you see. And there might be some of you on this call who are like, dude, I see like seven cavities or nine cavities or three cavities. And the problem with that is that, I went to dental school like you all did. I was taught by dentists about how to interpret radiographs and how to make treatment recommendations based on those radiographic interpretations. And one thing I could have done if I saw this kid when I was in dental school, one thing I could have done is I could have been like, hey, 17-year-old who's never had a cavity before, you now need nine MOs, DOs, and MODs. You now need nine class twos. And to be quite honest, my dental school instructor would have said, yeah, I see it. Yeah, I see all of those interproximal lesions. Yeah, go ahead, let her know. And I would have gotten it signed off. I would have gotten the green light from my mentor dentist that I could do nine MOs, DOs, and MODs on a 17-year-old kid. I would have stuck needles all over her mouth. I would have pulverized a bunch of enamel, and I would have stuck a bunch of class two matrices. Back when, in my day, it would have been Toffel-Myers, but then that changed into sectional matrix bands, and I would have done a bunch of DOs, MOs, and MODs. And how many of you would be surprised if 20 years later, when this girl is now middle aged, in her 30s or in her 40s, how many of you would be surprised to see x-rays that look like this? Now, what I see here is a big dental mess. I see a person who is going to have a very colorful dental future. And that's not going to be a big surprise for that person because they've had a very colorful and frustrating dental past. They were probably somebody who, as teenagers or young adults, they were told that they have a bunch of class two cavities. Those class two cavities were filled. They were filled to the best of the ability of that dentist. And then that person would, over the years, be plagued with the frustration of overhangs, gingivitis that's below an overhang margin, sensitivity, recurrent decay, marginal leakage, teeth that before just needed a class 2 cavity, but now they need endo, now they need a crown, etc. And that is kind of the timeline that a lot of us have accepted now over the years is tell a person when they're in their 20s, hey, you need a DO. And then 20 years later, when they're in their 40s, they're middle age, you say, oh, you know what? That DO that you had as a teenager, it has marginal leakage. There's decay at the margin. We're going to have to do a deeper filling. And then 10 years later, that tooth becomes a problem again. You have to do endo and a crown. A couple of years later, maybe 10 years later, they're in their 60s. That endo fails, the tooth needs to be pulled and an implant needs to be placed. And then 20 years later, that patient is dealing with periimplantitis. And this sounds extreme. It's not. I don't think there's one person on this call, and there's 209 of you, there's a lot of you. I don't think there's even one person on this call who would be surprised to find bite wing x-rays that look like this tomorrow when you go to work. I mean, this is commonplace. Everybody has bite wing. Every dentist encounters bite wings that look like these pretty frequently, daily, maybe once every 2 days. And that is a timeline in which we as dentists with the best intentions decided to do what we were taught in dental school, and that was drill on some teeth. And then over time, those teeth that we drilled on slowly started getting worse until that patient needed more invasive treatment done. One thing I want to make sure you all know is that this lecture is available on demand. If you know somebody who wants to watch this lecture and they weren't able to before, they can watch it. It's on the Catapult platform. You can do that. It's free. If you say 3, 4 months down the road, you're like, God, I got some nice advice from this lecture, but I kind of forgot some of this stuff. You can go out and Catapult. Catapult offers really high quality CE for free. And then all the notes that I have, a lot of times when I do a particular lecture, I send a PDF of my lecture to Catapult and I say, just make my lecture available for free online. And so I just want to make sure none of what I'm going to be saying today is a secret. I want you all to have access to all of the same stuff that I have access to. Okay. If you go on my website, you will find there is a link on my website, bebetterseminars.com, that just says handouts. All of my handouts for every lecture that I give. It doesn't matter if I give a lecture on ergonomics, about if it's a lecture on implant overdentures, if it's a lecture about how to hire and fire employees, it doesn't matter. I try to put high quality notes like the ones you see on your screen here. I try to put them on my website. They're free. I don't ask for email addresses or subscriptions. I don't ask for anything. You can just print my handouts and use them as you see fit. My goal is to make it so that dentistry is easier and more fun for people. That's why I'm giving this lecture today, and that's why I keep all of my content so readily available. So let's start with this first part, and that's diagnosis. And that is the fact that if my daughter had, let's say my daughter wasn't related to me, she came into my office, she saw me, I was a dentist, and I looked at those bite wings. There's probably a part of my brain would be like, damn, this girl got a lot of cavities. But the problem is that if she then drives down the street to a different dentist, there's a possibility that that dentist may not have the same exact number of problems on their problem list. And that's because diagnosis, by and large, by us dentists, is a very human and therefore a very flawed um, procedure. Diagnosing X-rays. I mean, think about it. So here I am, and I'm sitting there. I'm about ready to get started with, I don't know, a crown prep on this lady. And you know, the majority of my brain at that point, you know, is like, all right, I'm gonna do a crown prep on this lady. And then all of a sudden, Carly pops in and she's like, Gupta, Mr. Jones in 5, his crown still feels high. Can you come back there? And I'm like, oh, dude, really? Oh, man. I thought I was done with that dude. Okay, yeah, Carly. I'll be there. And then all of a sudden, Kathy's like, we're ready in op six. And I'm like, what? Op six? I didn't even know there was a patient in op six. Oh, God. Okay. Kathy, I'll be right there. What are we doing in op six? And then she tells me, and then my hygienist is like, I need a hygiene check. And then another hygienist is like, I need a hygiene check. I'm like, dude, I think that this is a very relatable and realistic scenario. And the thing is, my brain is only big enough to handle so much. So here's what happens. I walk into one of those hygiene rooms. I see this bite wing that's up on the screen, and my brain immediately goes, "Brrr." That's what I do. That's what happens. Because I'm human, my brain goes to that. And I'm thinking to myself now, I'm like, oh, dude, oh my God, this patient's going to be so frustrated. Patient came in, they just wanted a cleaning. They just were coming in for their 6 month cleaning. They were here 6 months ago. I must have missed that 6 months ago, whatever it was. And now I got to tell this patient, yo, patient, you know that tooth on your upper left that isn't bothering you at all? Well, it's going to need endo and crown lengthening. And then I'll be thinking to myself, can I do the crown? Can I? Is that something I can do? Do I have to refer that? I don't know. I'm looking at the x-rays and I'm thinking about that and I'm thinking, how do I tell this patient? And it's possible that while my brain is so devoted to this one scenario, I might just miss, I don't know, all these other scenarios. The fact that there's interproximal tartar in one, two, three, four, five, six different sites. The fact that there is incipient decay on one, two, three, four, five, six different sites. I might miss it. And frankly, if you don't think you would miss it, you're arrogant. You need to see a therapist or something like that because, like, all of us would miss this. All of us are human. Sometimes we get it all, and sometimes we don't. And that's because sometimes we are the best at what we do, and sometimes we're not. We don't get the best sleep, or we get into an argument beforehand, or we're thinking about our kid and we're worried about them. And sometimes we lose the focus that we're supposed to have. And the reason that artificial intelligence is so helpful for radiographic interpretation and diagnosis in general is because it allows us to be humans and it picks up the slack. It says, all right, human, you might have noticed, I don't know, that big chunk of decay that's on the mesial of 19. But I'm not sure if you noticed that chunk of decay that's on the mesial of 18 or the chunk of decay that's on the distal of 19. So I'm going to put a big box around those things so that it's a little bit easier for you to see. And that's what artificial intelligence does. It just allows us to be humans, try our best to be the best we can, but when we do miss stuff, artificial intelligence comes and it bridges the gap a little bit. Now, I'm not getting paid by this company. I have no financial relationship with this company, Pearl, but I will tell you that the company I use for my radiographic AI interpretation is Pearl, and I wanted to put the QR code for this up on the screen so that you know that it's there. Okay, so let's talk about five here. All right, so there's number five. And I believe, now, let's see, what is it? There's 200 something of you on this call right now. And let's say 25% of you are not even paying attention. You're watching Netflix right now. But the other 75%, you're like, I'm looking at five and I would do a filling on five. And yeah, of course yes, I mean, the vast majority of us dentists would agree. We would do a filling on 5DO. We would do a filling on that tooth because that's how it was taught to us in dental school. The decay is very clearly beyond the enamel. We were taught the rules. Hey, if decay extends past the enamel into the dentin, you got to drill, baby. Now I take that same radiograph and I look at it under artificial intelligence. And my AI interpretation is like, yeah, baby, there's that decay is extending past the enamel into the dentin. Now, what's really nice about AI is that it'll actually show us a percentage. Like it'll be like, oh, it's 3% in the dentin or whatever. Okay, that's pretty cool. That's kind of neat. Like that, my AI interpretation is going to give me more documentable data and evidence that says, yes, this patient has a cavity, and maybe it's a good idea for me to drill. So I do. I say, okay, well, patient, pay me some money. I'm going to drill on tooth number five. Tooth number five needs a filling. So I do. And this is what I saw when I did my initial prep. Now, I would say I'm a very, very conservative dentist. My preps look like this. I try to drill the very, very least possible. But when I drilled into that tooth, I was actually kind of astonished because I didn't really see very much decay. I kind of thought, God, where did I get it all? And so I grab my slow speed and I start to remove what I thought would be soft dentin because of the decay, and there just wasn't very much. You can see a little bit down kind of near the lingual. And for those of you who would say, well, good, that's fine, you did a good job, I would like to push back on that for just a moment. Because to be quite honest, I'm not sure that I would have wanted my daughter to get that DO on tooth number five. I'm not sure I would want myself to get that DO on tooth number five. I would much rather have pushed the timeline back and maybe made it so that that DO on tooth number five, maybe we don't have to do it for another 15 years and let that girl be a 30 something year old and then have the DO done. Pushing back the timeline where maybe by the time she actually needs endo on this tooth, she'll be dead. That'd be kind of nice. Because see, this right over here, in my mind, doesn't completely warrant the need to drill on a tooth. It doesn't warrant the need to get a person numb and drill. And if it was my own mouth, I'm not really sure that I would want that done on me. And here's where I want to introduce one piece of technology that probably the most of you don't use, and that's called transillumination. Transillumination is basically you take high powered light and you shine it through the interproximal via the buccal lingual plane. So now instead of looking at this tooth via a bite wing, I'm looking at it from the occlusal view down at a transilluminated surface. And what I would have found from looking at that, if you look slightly lingual to the point of contact, you would see that darkness that's on the distal of tooth number five. And I think all of you would agree that that darkness seems to stop right about at the enamel and dentin junction. Now, that was something that, had I not had transillumination, I probably wouldn't have been totally confident in what I was going to do. I would have said, well, the bite wing says I need to drill, so I'm going to drill. Okay? What transillumination does, it's basically an intraoral camera, but what it does more so than being an intraoral camera is it'll show me areas where there is interproximal incipient decay. It'll show me how deep that interproximal decay goes, and it'll show me whether or not there's active caries on the occlusal surface. And this is just one intraoral camera that allows us to see all of those things. And it's so easy. What it allows me to do is it allows me during just a regular exam, it allows me to just basically tour this patient's mouth, especially during their appointments where they're not even due for bite wings. It allows me to tour their mouth and it allows me to see whether or not there's any interproximal lesions. So nice. It tells me the buccal and lingual location of those lesions. It tells me whether or not those lesions have extended into the dentin. It's so much information that I wouldn't be able to get from a clinical exam, and I often am not able to get from bite wings. So first of all, it's a camera, just like your intraoral camera, only it's a little bit higher quality. It has transillumination, which is very, very helpful for interproximal spaces, and it shows us the difference between active and inactive caries. Active caries are a different shade of orange when you do the active caries detection mode. So if you look at this right over here, if you see that picture that's on the lower left, that's an intraoral photo. That's just a regular intraoral photo. That's a photo that, you see the old filling. The old filling looks kind of dingy, but you're not totally sure if you should be removing that old filling because you don't know if there's decay underneath. Now compare that picture that you see on the lower left to the picture that's right in the center. It's the same exact tooth, same exact view, only now it's being transilluminated. By transilluminating it, we can see a little bit about the extent of decay that's underneath the filling. That tells me a little bit more. And then the mode, the active caries mode, what it will also do is it'll tell me what's the difference between inactive decay, old fillings, and actual active decay. And what I was surprised to see is that that orange line that you see on the what would that be? That would be in between the distal and distal buccal cusps of that lower tooth that actually had active decay. This tells me a lot. This will guide me as to whether or not I should do non-invasive means, whether I should remove the old filling, whether or not I should be talking to the patient about a crown. This is a lot of information that I'm getting in a matter of like 2 seconds, just as I'm just waving this intraoral camera around in somebody's mouth. Okay. Now, if you look at the picture on the upper right, what you see is interproximal decay. You see this, it looks like a molar and a premolar that are next to each other. The premolar has had a filling before, and the molar has this big black dot that's right on the interproximal. An X-ray probably would tell me, you should probably drill on that thing, but I won't. I'm a conservative dentist, and we'll talk about my non-invasive means in a second. But I would much rather treat that tooth with some medicine, tell the patient a little bit about diet counseling, and let them go home. And hopefully, they won't need a filling in that tooth for another 20 years, another 10 years, or something like that. The picture that you see on the upper left, that is what looks like either, if you look at the molar there, it looks like maybe it's two different MO fillings or an MO filling that butts up against an occlusal filling. I don't know what it is. All I can tell you though is when I looked at that tooth clinically, I couldn't tell such a distinction because I didn't have the power of these different types of light. So let's go back to tooth number 5 here. So in this case, I actually drilled on the tooth. I removed the decay. It was a totally it was a what's it called? Like a bread and butter procedure. It was a piece of cake. It's all good. But look how much enamel I removed in order to do that. The patient had decay on the lingual part of that, but I removed all of that enamel so that I could open the contact. And in my opinion, I think drilling enamel is absolutely barbaric. Like, think about it. The rest of my body is just squishy and gooey and soft. And all of a sudden, I have these like things coming out of my gums that are hard as diamonds. And the fact that us as dentists, because we were given a license to drill on these diamonds that are coming out of our gums, we drill, we obliterate that crap. We crank that stuff up to whatever 200,000 RPM with a diamond burr, and we obliterate enamel. And the question is that good? Are we doing that patient a service? Well, in a lot of cases, sure, we are. When we're doing a crown prep or when we're removing decay that's deep, of course, we're doing a huge service to that patient. But is it always necessary? Is it always necessary to drill on enamel, given how valuable that enamel is when it is never been touched? I don't know. I believe that it's probably not. The second thing I realized after being a dentist for 25 years is class twos are freaking hard. They're just hard. Do you know why I took this? You know why I took this x-ray? Does anybody want to? Okay, I did tooth number 29 DO. I did tooth number 29 DO. And after I finished doing tooth number 29 DO, I look over at my assistant. I'm like, Danielle, take an x-ray. Take a bite of me. Take a bite of me. Do you know why I asked her to take a bite wing? The answer is I asked her to take the bite wing because I was so proud of the work I did. No joke. I'm not kidding. I was so proud. I was like, dude, I'm awesome. I'm the best dentist ever to exist. So take an x-ray so I can like look at this DO and like just ogle over how perfect it is. And then I looked at it and I was like, oh my God. Oh my, this is not a perfect DO. This is a piece of crap DO. Like I actually did this patient harm. I gave the patient gingivitis. I gave him gingivitis. Look at that. but the fact is, I didn't know that I did. I thought I did a great job. And look at what happens when we do class twos. We drill the decay out, we have a proximal box, and we put in the sectional matrix band of our choice. And because I'm an educator, I use them all. I use the Ultradent, I use the Garrison, I use the Premier Dental, I use the Dentsply, I use all of them because I get a lot of them as an educator. And I pop them in, and it doesn't matter which one you use. There's always a possibility that you might have a non-perfectly sealed cervical portion of your proximal box. I think the only one in this entire slide here that looks perfect is the one on the upper right. That's the only one. All the others are a little imperfect. There's a little bit of space where you can create an overhang. And is it because you're a bad dentist? No, it's because they're hard. Class two composites are hard. I don't want to do them. So let's talk about how to be non-invasive. If this is something that resonates with you, let's say you're like, dude, I don't want to do a ton of class twos either. I kind of hate them. Let's talk about non-invasive treatment. And I like to compare enamel to Nerf bullets. So my kids are old now, they're teenagers, but like 3, 4 years ago, my basement was just flooded with Nerf bullets. Like the basement floor was more Nerf bullet than it was floor. And so it was easy for me to just go downstairs and like reach over and grab a handful of Nerf bullets. And then I looked at them and I was like, oh my God, this is enamel. Now, the way that Nerf bullets work, or enamel works, is you have a bunch of Nerf bullets that are held together and you super glue them all together. And this big wad of super glued together Nerf bullets, that's what enamel is. But then you have sugar. You eat some candy, and the bacteria in your mouth consume that sugar. They squirt out a little bit of acid as the bacteria's little acid poop, and it squirts acid all over the enamel. And what that does is it dissolves the super glue that's holding the enamel together. Now you still have your enamel rods, but those enamel rods aren't held together by super glue. It's a process called demineralization. But thankfully, all of us have saliva, and our saliva is awesome. And so our saliva comes in a few hours later, and it's like, oh my God, oh no, there's a bunch of demineralized enamel. It's time for us to remineralize the enamel by re-supergluing that enamel together. Process called remineralization. And what is the very best exogenous remineralization agent? It's fluoride. Fluoride. Fluoride is the thing. So when you have a patient who has high caries risk, they have a lot of cavities, like my daughter, I would say, dude, you need to apply more fluoride to your teeth. How can we do that? And then, of course, if you lose enamel rods, that is called cavitation. So let's take my daughter, somebody who had a bunch of incipient lesions that I didn't want to drill on. Well, one thing I could do is just have her apply topical fluoride more often. Maybe have her come in once every 2 months or 3 months, not wait until once every 6 months for application of topical fluoride, which is a great idea. I use the Proficil by Catapult. They are not paying for anything. I don't have a financial relationship with them, but I just find their fluoride to be less gross than some of the other ones, and it's a nice price. So this is for those of you who have not tried the Proficil by Catapult. It's something that you probably would. It probably would be a good idea for you to just try it out and see how it compares to your current fluoride. And then look at all of these adjuncts that you can give to a person at home. All Day 5000 is the remineralization toothpaste or paste that has the highest percentage of fluoride. The 5000, I think, means 5,000 parts per million of fluoride. Remin Pro, which I think is the best tasting of all of those adjuncts. MI Paste, which is the OG. MI Paste is made of something called Recaldent, which not only utilizes fluoride, but it uses some other things to make it so that the enamel is stronger. This is all stuff that we can start giving to our patients to say, hey, patient, listen, you have cavities. You actually have a bunch of them. You have like 9, but I don't want to drill on any of them. I don't want to drill on any of them. Here's what we're going to do. We're going to come up with a plan. First of all, I want you to drink more water. Second of all, I want you to eat less sugar. Third of all, I want you to come in more often so I can apply topical fluoride. And fourth of all, am I at fourth? I don't know. Fourth of all, fifth of all, whatever. I want you to go home with one of these pastes. Okay? And you pick. You pick based on the brand that you like the most, which you might have a relationship with salesperson or whatever. But you then pick. Now, what are we going to do with those actual cavities? We're going to treat them with medicine. I'm not going to stick a needle in your mouth. I'm not going to drill in your mouth. We are going to rub some medicine onto those small cavities. Now, a lot of you have heard of SDF. For some weird reason, not all of you use SDF. I hope that changes tonight. I hope that changes tonight. At some point in the last 10 years, some idiot said that SDF turns the teeth black. And what happened was more than 50% of dentists were like, oh, it turns the teeth black. Oh, I can't use that. My patients will be so angry at me if I turn their teeth black. And as a result, because of whatever idiotic education that we got about SDF, a large majority of dentists don't use it. And what that means is we do one of two things. Either we ignore cavities or we drill on cavities. And if you look at these two small, little black lesions that this patient has on these premolars, I think most of you would agree, I wouldn't want that drilled on. I certainly wouldn't want those drilled on in my mouth. I don't want to drill them on somebody else's mouth. SDF is a wonderful option. Yes, does it turn the decay black? It does. But it doesn't turn the tooth black. It turns the decay black. And it's very effective at arresting the progression of decay. SDI, again, not sponsored. I just wanted to make sure that you have access to their Rivastar Aqua. If you're not already using silver diamide fluoride, please, I welcome your argument. If you want to send me an email and be like, yo, Gupta, I don't use SDF, and here's why, please tell me. I won't be a jerk about it because honestly, I can't understand why any dentist wouldn't. But then I got a case like this one here. This patient who has interproximal incipient lesions between 18 and 19. And when I was in dental school, I would have not just done an MO or a DO. What I would have had to have done is tell my instructor that I will remove all of the old fillings on both of those teeth. Yes, I would have removed all of that occlusal amalgam on 19, all of that occlusal composite on 18. And if that amalgam or that composite took up a lot of the occlusal surface, what I would have ultimately done is tell the patient, oh, hey, patient, you need a crown. Yeah. You need a crown. You need a $1,500 two-appointment procedure for these tiny little lesions that are about the size of a grain of sand that are not hurting you. I'm going to have to get you numb. I'm going to have to pulverize your enamel and then make you something very expensive. And for any of you who are like, I don't see the problem with that, just ask yourself, would you do that on yourself? Would you do that on your daughter? Would you do that on your teenage son? And if the answer is no, then we got a problem because it means that you are not obeying the cardinal rule. The cardinal rule, the number one rule, the rule that every religion has. Every religion says, follow the cardinal rule. And that is, I will do to other people only what I'm comfortable doing to myself. And I would never want a crown done on myself for one of these teeth. I wouldn't even want them drilled on. So what can we do? Well, SDF is a good option, but there are patients who are like, I don't want anything to turn black. I don't care what you say. I don't want nothing black. I love my teeth. I love my super white teeth. I don't even want a white halo interproximal. And in a case like that, a wonderful solution for those patients is something called Curodont. Curodont is, and again, I'm not being paid by Curodont, no financial arrangement with Curodont. It's just a sweet product. It is something that will arrest decay, remineralize incipient lesions, and it doesn't turn anything black. Okay? So you have this patient right here, very similar to the last slide, 18 and 19, both with incipient decay. What I tell the patient is, okay, while you're right here in hygiene, I'm going to express some medicine directly onto those kissing cavities, those kissing class twos. So what the Curodont, the way the Curodont is delivered is this. You basically have this little tube of liquid, and you can squirt that liquid onto a sponge. That sponge has all the magic. All the magic is on that cuboidal sponge that you see on the bottom of the screen, at the bottom of that little plastic thing that I'm holding. Okay. You let the liquid soak into the sponge for a couple minutes. And then while that's soaking, you go over to the patient and you have to do the following procedures. With completely unwaxed floss, you're going to slide some floss in between there. What you're trying to do is you're trying to remove any of the salivary pellicle that is in between those teeth. Second thing you would do is you would squirt a little bit of etch in between the teeth. Now, obviously, because it's a close contact, it's not like you're going to get etch everywhere. So what I do after I etch is I also take some floss and I want to see if I can get floss to smear the etch all over that interproximal surface, rinse it off. Now, my hygienists don't have an isolite, so I must have done this in my dentist room. Having an isolite is the bomb. Like, I love it. So I like doing this procedure with an isolite, but if you want to do this with the convenience of doing it in your hygiene room, then you probably won't have an isolite. And then you just smush this sponge right into that interproximal surface. That's it. There you're done. Now, I charge my patients per application, not per site, because that patient had 19 MO, 20 DO. I wasn't going to charge them twice, even though I was just using one sponge. The one bad news, though, is once you use a sponge, once you do one smash, that sponge is now, it's all the magic is gone from it. You're going to have to use a different sponge for a different site. And if that's the case, you're going to want to charge your patient per sponge rather than per site. Okay. Remember, SDF is going to arrest cariogenic bacteria. It will not replace lost enamel rods. Fluoride varnish is wonderful, but it's highly superficial. It's not going to penetrate any more than 25 micrometers. Curodont is going to have the deepest penetration, and it is going to replace those last enamel rods. This is the QR code for Curodont. Okay. The one problem that I have with non-invasive intervention is I'm of the belief that, well, if I'm going to go through all this, like, isn't the x-ray going to look like more awesome 6 months later? Like, if the patient has interproximal incipient decay, then when they come back in 6 months later, it's all going to be gone, right? And that's just not how it is. Most of the time, patients come back and the decay looks exactly like it did 6 months ago, which in a way is a good thing. It's good news. It means that the decay didn't get any worse. But the process of full remineralization to the point where it's evident on an x-ray is generally a many-year process. So the question is, how do you know if you got it? How do you know if it worked? And the only way that you know if it works is by testing the pH of cariogenic bacteria in the area. So this is one of my assistants, Jadriana. She had a cavity in between teeth 4 and 5. She did not have a cavity between 2 and 3. No. She did not have a cavity between 3 and 4. She did have a cavity between 4 and 5. So I made her eat this little gummy thing. And then I took a pH stick and I stuck it in between the teeth. That's all this thing is. It's a pH stick. It's going to change colors in a lower pH. So because she ate something sugary, if she has active bacteria that's in that area in an active decayed area, what's going to happen is that bacteria will eat the sugar, it'll start squirting out acid. And all of a sudden, you're going to have a reduction in pH. And so what I found was in the area where I knew she had a cavity, the x-ray showed, the transillumination showed, sure enough, it turned yellow. The pH stick changed colors. And in the area where she did not have a cavity, it stayed purple. This is a really nice, effective, inexpensive way for you to test whether or not your non-invasive treatment actually worked. This product is called CaviSense. Again, I don't have any relationship with them. I just want to make sure you have easy access to maybe getting a product, trying out one of their products. Okay? All right, so what are you going to do? You have a patient, they have some decay. You don't want to drill on it. In the office, make them some trays. provide prescription strength toothpaste, apply SDF or Curidont, apply fluoride more often. And then the thing that you're going to encourage them to do at home, along with drinking more water, eating less sugar, is brush with the toothpaste that you provided. Have them wear their trays that have whatever remineralization agent in them. And then if they're going to have something sugary, have them eat some type of pH balancing chew like Cavity Fighter. But then there are times where you really just want to get rid of that stain or that decay or that grossness. There, I still am, I still think that there's something in between using a drill and using these non-invasive medication-based treatments. And that is something called air abrasion. So, this is one of our patients. She had a very clear stick on this, what is this, tooth number 20? She had a very clear stick on tooth number 20, kind of right at the very top of the distal buccal groove is what you, I don't know, whatever it's called. So there's the buccal cusp. If you look at the distal of that buccal cusp, you see that little black hole there. Okay. And there was a stick. Earlier in my career, I would have been like, all right, I'm going to numb you up and I want to drill on it. I'm later in my career. I've been a dentist for too long. I don't want to numb this patient up. I want to be able to do this filling in the most non-invasive way possible. How am I going to do that? I'm going to use something called air abrasion. So instead of getting her numb and drilling, I'm going to use a product that is going to blast what is called aluminum oxide, blast small aluminum oxide particles into that area. What I'm basically doing is I'm air abrading all of the enamel that has been undermined by that cavity. That enamel will come off. Okay. It's a little bit more of a time-consuming process than drilling on the tooth, but the patient is not numb. They didn't even flinch. Okay. So what does air abrasion do? Why am I so happy that I have air abrasion in my office? Well, it's not just for these very, very non-invasive or minimally invasive procedures, but also like anytime that we're doing sealants, we always blast with air abrasion. It's so much nicer. How many times have you been tempted to do sealants, but the patient has stain in their grooves? Now you can just like literally, it's like taking a digital eraser and you just erase all of that stain. One thing that we do every time for our crowns prior to seating is we air abrade them. It increases the chances that we're not going to have any type of debonding with our resin-based cement. In cases where crowns have come off and they're all nasty underneath, patient comes in, they're like, oh, my crown, my PFM from 30 years ago came off. Can you re-cement it? Well, a lot of times I can. The tooth is in good shape, but I want to like get rid of all the yuck that has accumulated underneath that crown over those 30 years. Air abrasion is a really nice way to do that. Let me pause this. It's distracting. Any overhanging enamel over small cavities, air abrasion is very, very effective at removal of stain around old restorations, removal of debris for diagnosis. All of these things air abrasion allows. I only have one air abrasion handpiece, and maybe I might get two in the future, but my air abrasion handpiece it's so mobile. We're able to use it a few times every day. And that's just because it has so many different applications, but I'm not breaking the bank trying to equip every single one of my operatories with it. It's just a really, really, really nice product. Okay. Just like I said earlier, Cavo is the sponsor of today's lecture, and the air abrasion handpiece that I use is the Rondo Flex, which is a Cavo product. And so the Cavo rep who is on this call, he'll be able to give you, his name's Trevor, he'll be able to give you a little bit more information about air abrasion once we get to the question and answer and afterwards. So here is Millie's tooth before I worked on it. And here is the active, this is just confirmation that there's active decay right there where I was able to find a stick. And this is what the tooth looked like after air abrasion. So I basically spent, I would say maybe 40 to 60 seconds just air abrading up and down from the distal buccal down to the distal central, I guess we'd call it, over and over again. Patient felt no pain. There's a little bit of debris from all of that aluminum oxide. So after I cleaned it off, this is what it looked like. I was able to just go ahead and do a filling, and I was able to do so in a very, very minimally invasive manner. And it's something that I'm proud of. I don't think that this tooth is going to become a problem in the future. And frankly, I know that my bond is the highest quality freaking bond you can get because I air braided the crap out of the tooth beforehand. It's like all of the salivary contaminants that could ruin a bond, they're all gone. And so there's a very good chance that 50 years from now, that filling is still going to be looking very good. And it's thanks to the fact that I used minimally invasive dentistry. Okay? This is all a win. When you have a patient and they have decay, everybody wins. The patient doesn't have to get numb, they don't have to get drilled on. They don't have to spend $200 for a filling or $1,500 for a crown. For the dentist, you don't have to spend 60 minutes doing 18 MO and 19 DO, which to me is a soul crusher. Seeing two kissing class twos on a 60-minute appointment on my schedule, I just want to like, ugh. I just think back to the days when I got into dental school, and I think, man, maybe I wish I hadn't gotten into dental school. I don't have to break my back doing a difficult procedure. And then our hygienists, they win so much because when they see this, they're adding so much high quality production to their normal appointment. SDF, Curodont, trade therapy, more applications of fluoride. They're increasing their production without breaking their back, doing traditional scaling, which is what they were kind of trained to do. Okay. Here are some of the codes that I think a lot of you will find helpful. And I created this little Canva, like, what's it called? I think it's, wait, Canva? Yeah, Canva. I created this thing on Canva, and it's just basically this like one half vertical sheet that says, "Oh, you were just told that you have some cavities. We're so sorry. Nobody likes hearing news like that. Let's follow these steps." And then I give him home care instructions. I give him diet instructions. I talk a little bit about the non-invasive things that we are able to offer for the patient. Now, if you want to copy this, it's on my website. You can literally go to my website, find the link to this Canva, and of course, go ahead and open it up, delete my logo, delete the picture of me and my wife, replace it with you and your team, and then you can delete my website and all that kind of stuff and make it your own. I don't like anybody having something that could benefit a lot of people and keeping it secret. This should be for all of us. And so if you want to copy my non-invasive, I don't know what you would call this little pictogram that talks about people who have a lot of cavities and gives them some advice, please feel free to take that. I also have a Canva link on my website for patients who are mouth breathers, who snore. I have one about periodontal disease. Please, by all means, just take mine, delete my website, or delete my logo, and make it your own. And look it over. And if there's something that you don't agree with, delete it and put something that you like better. Let's be a collective and try to offer the best possible care to our patients as a collective. Okay. So with that said, I do want to, oh my gosh, it's 8:48. I finished right on time. A couple things before we do Q&A. Number one is for those of you who do like to do social media, all of the things that I talk about, whether it's implant stuff or, prepping a crown or, getting really nice margins or effective ways of cleaning off any salivary contaminants, blah, blah, blah. I do videos. I put them on my Instagram. I try to make them very helpful. I also put them on Facebook. All my handouts are available on my website, BeBetterSeminars.com. If you just have a question and you're like, I just want to reach out to this dude, feel free to email me. I'm not very prompt in my responses, but I try to respond to everyone. Where's the Q&A? Here we go. Okay. Paris Murray Donna Stork. I use Prophecyl. How often would you recommend me applying it at home for me and my kids? Oh, so Paris, I don't apply Prophecyl at home. So my daughter, let me just tell you my daughter's protocol. We made her bleaching trays and we gave her Remin gel. And so we are now Riemann gel is a daily use thing that's in trays. So my hope is that every night before she goes to bed, she wears her trays with Riemann gel for 10 to 15 minutes. When she comes in for her cleanings, we use Prophysil, and I asked her to come in every like about halfway through her cleaning, so every 3 months, so that we can just place another Prophysil. So yeah, I'm sorry if I was unclear about that one. I'm going to go ahead and mark that answered. Paris also, how do you recommend using the SDI Revstar Aqua interproximally? Honestly, it'll get there. It'll get there. Because I'm an educator, I've had the opportunity to um, watch lectures from various different minimally invasive and non-invasive dentists, and actually the properties of SDF and Curodont, they leach very, very efficiently, even though there's a contact, like a physical contact, right? Like that our Explorer can't get through, liquid fluid can get through there. And so all you need to do, honestly, with your Riva Star is just smash that sucker all over the interproximal area. Try to maybe get your microbrush to go under the contact spot so that it's kind of smashed between the papilla and the contact. The only problem with Riva Star is that you want to just be very, very, very ungenerous with the amount that you use. If you use a lot, it kind of makes the gums have a little bit of a reaction to it, and so you just want to be careful. Let's see. Matthew Bradley. Why wouldn't you always use Curodont for all incipient lesions? Okay, because Curodont's more expensive, and I practice in um, a lower middle class blue collar environment. So we charge for SDF, we charge, I think I'm right, $40 per application. And then for Curodont, we charge $75 per application. And so we make that clear to our patients um, when we talk to them, and we let them decide. But I would say that there are times when patients, if they have 9 cavities, they just don't have the money to spend $75 per cavity. And then we say, That's fine. We still have another option that's going to be quite effective for you. Um, though our preference is that you use Curodon. Okay, Paris, what is the PSI on your air abrasion? Dude, great question. I have no idea. Trevor, do you know what is the default PSI for the Rondoflex air abrasion?
Yeah, you're gonna control the PSI of the powder that's being ejected by the foot pedal. So the harder you push, the stronger it will be. In general, you'll have that line set at around what you're using for a high-speed handpiece.
Hmm. Can you just
Yeah,
tell me what that
but
is?
yeah, it's going to be around 40, but it also that's a little difficult because the PSI reading will change depending on what instrument you put on the line. So I'd say
Got it.
if you have a high speed on there, set it around 40. That's good for an air abrasion unit, and then you can also control with your foot pedal based on the results that you're seeing.
Okay. Okay, that makes sense.
Yeah.
So Trevor, like let's say in a case where a patient isn't numb, they have a little bit of old cement still on their tooth, and I just want to
hmm
blast it off. I might just use a little less pressure with my foot pedal.
Yeah, you can always start slow and add more if you want to see whatever you're trying to remove go away faster.
Awesome. All right. Thanks, Trevor. Okay, next one, Paris. So hygienists can apply Curodont. Now, hygienists can apply Curodont in Ohio. I don't know if hygienists can apply Curodont nationwide. So I would say it's probably a smart idea for you to just check with your dental board. They used to be calling the dental board. Now all you got to do is just have like Google Gemini find out for you. More than likely, you're going to get an accurate answer there. Okay, Shannon, how deep does air abrasion penetrate without causing discomfort? So I believe that I have penetrated through the enamel. I've gotten into the dentin, and I haven't had patients like jump out. I don't know why that is. I'm wondering it's because there's something about air abrasion that is more gentle than actual metal, like the burr actually demolishing the dentin like that. Trevor, do you have any
Let,
idea?
yeah. So less vibration, less heat. In general, less traumatic for the tooth, less chance of microfracturing. There's all sort of reasons why the patient wouldn't feel it quite as much, but you will hear some dentists will say the closer you get to the dentin, the more they'll feel it, and that's when you go easier on the foot pedal, or you can also just lower the PSI on that line if you want it to go
Or
lower
get
all
them
the
numb.
time. Yeah,
Or get them numb.
or get them numb.
Yeah, yeah. I think I would just get them numb. At that point, I'd be like, it was a good try. Let's just get them numb. Okay. Carrie, I just want to say this was a great lecture. Oh my God, thank you. Carrie Benvenuti. Hopefully, at some point, Carrie, as I lecture various places in the country, if you come to one of mine, please reach out because that was just a nice thing to say. Thanks for the presentation. I was wondering if you ever use Icon. Okay, so let me tell you about Icon. I think Icon is a very, very close competitor to Curodont, Jessica. I don't know as much about Icon except this. It's so expensive. And so I think for a case where, like my daughter, where she had so many interproximal lesions, it just might have been cost prohibitive. Like, well, it wouldn't have been cost prohibitive because her dad's the dentist, but it would be cost prohibitive for some patients. The one place where I think Icon does an extremely good job is for patients who have those white spot lesions, especially after ortho. I think Icon is number one. I think it does an excellent job at eliminating a lot of those white spots. I need to do more Icon cases because I would like to teach about it more often, but my knowledge base is too low about Icon. My thoughts about the Diagnodent. I think the Diagnodent has a lot of merit. It's just, I feel like when I was in a position where Diagnodent was very, very popular in the market, it was during a time in my professional career where I just didn't have a lot of the same type of additional income to invest in certain technology like that. And then once I started to, I became aware of, I guess, other toys that were more fun, like the Diagonocam or, guided biofilm therapy, etc. And so I never really got a chance to use Diagonodent on a regular basis. It does seem, though, like it has a lot of merit.
Can
Um,
I add to that,
yes,
Dr.
please.
Gupta? Yeah, so the Diagnodent is tried and true, but it's a mainstay, for a lot of years, but it has kind of a narrower scope diagnostically than Diagnocam does. So really, you mainly are going to use it on um, like basically class ones, and they have to be virgin teeth, and that's all it's really good for. Versus something like Diagnocam, the scope is really broad. You can see occlusal lesions, proximal lesions, cracks, secondary decay, and all the stuff that you're much more likely to see on every patient.
Perfect. Oh, that's excellent. Thank
Yeah,
you.
and someone wrote in the chat about false positives. That's the thing when you're using a Diagnodent and it's giving you just a purely quantitative reading, like a number. You just don't always have the context. Is it giving you a higher reading because maybe there's still some surface plaque there or something like that?
Perfect. Thank you. Go ahead. Sorry about that. Okay, an anonymous attendee said any opinion about air abrasion versus Solea or any other of the hard tissue lasers? Honestly, hard tissue lasers are so badass and so incredible and so amazing, and I would love to get one. I'm just not yet ready to drop the $75,000 on a Solea or a Photona or a Deca or something like that. And so when that time comes, when I do invest in one of those, it's going to be sweet, and I'll probably be able to give more information about that. But I just, one thing that I try very hard with all of my lectures is to be as relatable as possible. And I think that the vast majority of us don't have hard tissue lasers for just that reason. It's a large investment. Naya, for Curodont, can you use the sponge on multiple teeth? No. Once you do one smash with that sponge, all the magic is gone. You got to throw it away. One smash, one site. Now, if you have kissing class twos, those two sites can get one smash because you're basically applying the medicine into one place. It's just distributing to both of those class twos. But don't get don't get cheap about your Curodont because it is going to be much less effective. Okay. Jessica, is it 40 per site per tooth for SDF? Okay, no, it's $40 or $70 per application. Okay, so this is what I mean. Kissing class twos get one application. However, if I have tooth number 19 and the distal of 19 has a cavity and the mesial of 19 has a cavity, I'm going to have to do an application to the distal and an application to the mesial. That means I'm charging that patient 150 bucks. It sucks, but remember, when you smash that Curodont, all the magic goes. Okay? If you want to be a little bit more generous with your SDF, I feel like my SDF price is pretty reasonable. It's less than what I hear from other people, and so I'm comfortable with those costs. The powder for air abrasion is aluminum oxide. Is that correct, Trevor?
That's correct.
Okay,
About
great.
the micron size, 27 microns is the more commonly used one, especially intraorally. I mean, it's all up to your clinical judgment, but there's also a 50 micron particle size. You'd use this extraorally, like if you wanted to sandblast intaglio of zirconia, something like that.
Got it. Oh, great. Actually, thank you. I didn't know that.
Yeah,
Anon
you're supposed to sandblast those, by the way.
Yes. Oh no, I do sandblast. I just have never used a different
Mm.
use the same
Yeah,
we
go with
do
the
the same
bigger
one.
one for that, a little more effective.
Okay, cool. Anonymous, when gums turn white after using Revastar. Okay, so this happened to us in a major way. Like we way overused Revastar. We got it on their lip. I mean, their mouth was like a mess. I actually sent him to urgent care because I didn't know what to do. Everything turned out fine. I mean, everything just ended up working out. I actually called SDI in Australia and I was like, yo, you need to tell me what to do. Um, Within a day, the patient was back to normal, but it was very scary. What I want to tell any of you who are going to use Rivastar Aqua by SDI is the tiniest, tiniest bit. I mean, it's almost like you dip your microbrush into the solution and then wipe a little bit on your glove before you apply it to the tooth because, I mean, that stuff really spreads. Would you ever do a sealant over SDF? I have not ever. I just feel uncomfortable combining combining these things, and I've never had another educator who I know and I trust and I like say that they've done it. So I just haven't done it. I would much rather just do SDF and then maybe 6 months later air braid the crap out of that tooth and put a sealant on it or something like that. Jessica, what size microns? Oh, okay. Trevor answered that. Thank you, Trevor. And could you share the 88 codes again? Yes. So let me go there.
Question about if aluminum oxide is poisonous. It is not toxic at all. It's not reactive. The only contraindication is that it could be an irritant to somebody who has asthma if they breathe it in, or it can cause some mechanical irritation as well against soft tissue.
Hmm. Hmm. I would recommend using either a isolite or a rubber dent.